Okay. Good afternoon, good morning, good evening to everybody. We are here with this IFF webinar series on pre-IVF progesterone use protocols. We will have the presentation by Sezcan Mumusoglu, is an associate professor in Ankara, Turkey, at the Accept University School of Medicine. He wrote a lot of works. He did a lot of work with progesterone, and we are very exciting to hear his presentation. So I leave the theater to you, Sezcan, and we are at the end of the presentation. We will have 45 minutes for question and answer. That so we will go out of this webinar knowing everything about the pre-IVF progesterone use protocols.
Thank you, Paula, for kind introduction. It's my pleasure to be part of this webinar series, and I'm sharing my slides. If the technical equipment allow me. Kelly, could you please make me host? Okay.
Okay.
Thank you. Thank you again for the kind invitation by Luca Generali and Edgar Mocanu. It's my pleasure to be part of this webinar series. Today, I would like to discuss with you in the next 35 minutes pre-IVF progesterone use. It's a wide, broad title for this to discuss actually. I will try to do my best. I wish you a very fruitful and influential webinar. There is no conflict of interest associated with this presentation. Since progesterone can be used for several aspects, various aspects before IVF, I prepared an agenda as follows. First, I would like to discuss with you the progesterone use for follicle synchronization and progesterone use for scheduling IVF cycle. And then I will discuss the progesterone use to induce the withdrawal bleeding in anovulatory cases. And also I will discuss the progesterone use for the treatment of endometrial pathologies and move forward with the treatment of endometriosis before IVF. Actually, I am not sure that progesterone prime stimulation is under the topic of this title, but I know the webinar series, upcoming presentations, and it's not covered by the other presentation. After the internal discussion, we decide to present here the progesterone prime ovarian stimulation. As a clinician, every day we encountered a patient on the first day of stimulation with a growing follicle higher than 9 millimeters in diameter. When we start ovarian stimulation, it ends up with the asynchrony up to 50% in the cycle. Actually, this reduced the efficacy of ovarian stimulation. Several decades ago, some publications tried to do pre-treatment to reduce the number of asynchrony in ovarian stimulation cycle to maximize the efficacy of the treatment. Estrogen, progesterone, and combined estrogen and progesterone pills are used for this purpose. Also, GnRH antagonists have been used, aim to reduce FSH and LH, starting a standard cohort, synchronized cohort, end up with a good response. Actually, few publications available up to date in the literature for such an important topic. 4 small-sized RCTs compared the reproductive outcome and the stimulation performance. A recent cohort published in 2017 when compared the number of oocytes retrieved across the different protocols. The number of oocytes retrieved were similar between the treatment and no treatment group. Testosterone, noretesterone is the main progesterone used for this purpose actually during the progesterone pre-treatment in these 4 studies. When we compare reproductive outcome, higher clinical pregnancy rate were reported. However, when we compared live birth rate, only 2 studies with small sample size reported no difference. only advantages of using progesterone for pretreatment starting from the mid-cycle of IVF cycle, previous cycle, in mid-cycle of previous cycle before the ovarian stimulation cycle, actually reduced to a cyst formation at the beginning of the cycle. Based on the low quality data and small sample size data, recent ovarian stimulation guidelines do not recommend routinely use of progesterone to increase the efficacy of ovarian stimulation cycle. Actually, they acknowledge the use of progesterone not only for the synchronization but also scheduling purposes of the cycle, and they suggest as a general practice point it's acceptable to use progesterone for the purpose of cycle scheduling. I should like to take your attention the use of OCP for pretreatment. Actually, also they include the progesterone. If you use OCP more than 10 days, according to the literature, between 12 days to 25 days, it's associated with significantly lower live birth rate, according to 6 randomized trials, including more than 1,000 patients. So please be careful with the use of progesterone. I should acknowledge that the included studies did not take into account and heterogeneous in terms of washout period between the cessation of the OCP and starting day of the stimulation. What about the scheduling of our cycle? As a clinician and actually the laboratory person, we sometimes need to adjust the workload according to laboratory laboratory personnel number and also the equipment number. So scheduling is a really important point. In Europe, we all know that most of the clinics are using progesterone for scheduling, but unfortunately, not too many studies available published in the literature. I would like to discuss with you the recently published Fischl protocol. Dr. Robert Fischl from Hamburg provides his protocol is a publication and recommend to use norepinephrine starting around the cycle day 20 and use it for 7 to 14 days and recommend to stop it 5 days before the ovarian stimulation. Ovarian stimulation started, they should be adjusted and it should be planned to start on Friday, Saturday, and Monday to end up with the egg retrieval during the weekdays. By this way, you can schedule your workload also, you can avoid the weekend and holidays egg retrieval procedures. Actually, this protocol has been validated by the other different setup in Brazil with the Dr. Esteves clinics, and they compared the result and across the different age, they reported the almost identical reproductive outcomes, namely using progesterone for pretreatment without jeopardizing the reproductive outcome may have benefit for scheduling our oocyte pickup day. Another point for progesterone is before IVF to induce the withdrawal bleeding in oligoanovulatory patients. These patients are most likely PCOS patients, and unfortunately, not too many studies dealing with this question. I would like to discuss with you the only study. This is the secondary analysis of the study published in 2016 in New England Journal of Medicine, which is comparing fresh and frozen embryo transfer in PCOS patients. Actually, the menstruation induction is not randomized. In the secondary analysis, only the clinician preferences was the reason for the groups, and combined oral contraceptive pills was used in the vast majority of the cases, and micronized progesterone or dydrogesterone was used 1/5 of the cases, and control group served as a spontaneous menses group. When we compared the fresh transfer cycle for those 3 groups, actually oral contraceptive groups associated with significantly lower estradiol level, significantly lower LH level on the trigger, and significantly lower endometrial thickness. Regarding the reproductive outcome in fresh or frozen embryo transfer, oral contraceptive pills as an inducer for menstruation is significantly associated with significantly lower ongoing live birth rate when compared with the control group. And also in frozen taught embryo cycle is associated with significantly higher pregnancy loss rate and lower live birth rate. There was no difference between the control group and the progesterone treated group. Actually, despite the potential risk of selection bias on this study, we may say that progesterone used for withdrawal bleeding yield high rates of live birth rate when combined with the combined oral contraceptive pills. Progesterone can be used also treating endometrial pathologies prior to IVF. The most commonly encountered pathology related with the endometrium during the IVF treatment is endometrial hyperplasia. This Cochrane review compared the treatment outcome with levonorgestrel IUD versus non-intrauterine progesterone, and non-levonorgestrel IUD regression rate was significantly higher with the levonorgestrel IUD group when compared with non-intrauterine progesterone group. In non-intrauterine progesterone group, regression results around 72% rate, while it was around 85 to 92% in levonorgestrel IUD group. What about the early stage of endometrial cancer? We need to treat those patients in a fertility preservation manner to move forward with the IVF. Actually, in those cases, the performance of levonorgestrel IUD is well. It's around 63% regression rate. And also, we should keep in mind that the relapse and recurrence is around 30% within 2-year follow-up period with the treatment of levonorgestrel IUD for the early stage of endometrial cancer. Once we reach the complete response, namely after 6 to 12 months, there is no residual disease with the sampling. It means that complete response, if we could achieve the complete response, it's associated with good reproductive outcome, regardless of the treatment, how you achieve the complete response. It's the pregnancy rate reported around 40 to 60%, and 80% of those cases could get pregnant, end up with the live birth rate. The important point for those cases during the follow-up, sampling seems to be, according to recent meta-analysis, should be via hysteroscopy, because hysteroscopic sampling for the follow-up is associated with significantly higher pregnancy rate, lower miscarriage rate, and higher live birth rate when compared with the dilatation and curettage. It means that dilatation and curettage made a traumatic effect on the basal endometrium, compromising the implantation in the upcoming IVF cycle. The interesting thing is that the polyp is most commonly encountered in infertile group of patients, but it's only associated with around 1% of the cancer risk. It can spontaneously resolve during the follow-up period. It's around 25%. The gold standard for treatment and the diagnosis is the hysteroscopy. I'd like to take your attention for the only first article dealing with the treatment of polyps with sub-Q progesterone administration during the luteal phase for 3 months. It's associated with the significantly higher regression rate when compared with the standard no treatment follow-up. I do not mean here we should treat all the polyps with the progesterone, but I'd like to take your attention that progesterone might be used for this purpose. Progesterone for treating endometriosis prior to IVF is another debatable topic. Actually, we all know that progesterone can be treated with, endometriosis can be treated with progesterone, and it's efficient for the endometriosis-associated pain. Several progesterone types has been used previously, and almost all of them is efficient to reduce the endometriosis-associated pain. The question is, as we all know, during the IVF cycle, long suppression might be related with favorable outcome in IVF. Actually, recent Cochrane refused this hypothesis. But the question, if we if we suppress the disease for 2 to 3 months before IVF with progesterone, would it be beneficial for our cases? Available 5 studies is pulled in a recent meta-analysis. 3 of them are cohort study, 2 of them are randomized trial, including more than 500 cases. Overall, there is no differences in live birth rate when we compare Dynogest treatment with non-Dynogest treatment. Dynogest treatment actually. However, when we look at the subgroup comparisons, Dynogest treatment is associated with significantly higher live birth rate when compared with the no treatment patients, but it's associated with lower pregnancy rate when compared with the long agonist protocol. Similar outcome was yielded with treatment of Dynogest and dydrogesterone group. Overall, this quality of the data is very low, but the live birth rate following Dynogest treatment might be significantly higher than observed when compared with non-treatment group, and we need further evidence to make firm conclusion on this point. Also, different progestins should be tested for this attempt. The hot topic related with the progesterone use during IVF is the progesterone primed ovarian stimulation protocol. First baby was born with natural cycle in 1978, and during the first decade of IVF, we used HMG only protocol without pituitary suppression. And the second and third decade, GnRH agonist was the dominant protocol for pituitary suppression, and during the mid-third decade and fourth decade, antagonist protocol, because of the safety advantages, become the predominant protocol for the pituitary suppression. We first met with progesterone primed ovarian stimulation in 2015. The first report was infertility sterility in that year. The advantages of PPS protocol is lower cost, fewer medication, and permit us GnRH agonist triggering to avoid from OHHS. Disadvantages is due to the detrimental effect on endometrium. Only frozen embryo transfer is an option. We could not move forward with the fresh embryo transfer. From old studies, we know that high progesterone can block a late surge, but we actually did not understood clearly yet how progesterone is working in HPO axis. Progesterone priming seems that slow the pulse frequency and pulse amplitude, and then reduce the plasma concentration if we use during the ovarian stimulation. Previous pharmacokinetic, dynamic, and pharmacological studies showed that all progestin have in common the so-called progestogenic effect, and ovulation inhibition dose was defined from the pharmacological studies. But when we look at the real life data and recent publication, different types, different doses of progestin have been used to block a late surge. And when I summarized all the data from 4 randomized trials and 2 retrospective trials in this table, it's briefly I can say that 20 milligram dydrogesterone is equivalent to 4 to 10 milligram medroxyprogesterone acetate, and it's equivalent to 100 to 20 milligram micronized progesterone in terms of LH suppression. This is the first study that we met with progesterone primed ovarian stimulation protocol, comparing the medroxyprogesterone acetate twice daily with short agonist protocol. And of the included 150 patients, only one ended up with the premature LH surge. And regarding reproductive outcome, cumulative pregnancy rate per woman were similar between those group. All patients underwent a freeze-all cycle, and frozen embryo transfer was performed. Following this trial, several publications have been made. A recent systematic review, very nicely prepared, compared the PPS protocol with GnRH antagonist 1. Of the included 10 studies, 3 of them were randomized trial. Total gonadotropin dose consumption were similar between progestin and antagonist group, and number of oocyte retrieval again were similar across the studies. The sensitivity analysis comparing the different group of patients, including the PCOS patients and diminished ovarian reserve patients, yielded similar and comparable results. When we compared PPS with agonist protocol, 6 studies were included to the systematic review. 2 are RCTs. Of the included 6 studies, 2 of them is long agonist protocol, 4 of them is short protocol. When we compared total gonadotropin dose, you can see in the first graph a huge variation between the groups, because some of the paper are short agonists and some of them are long agonists. Overall, number of oocyte retrieval and total gonadotropin dose consumption were similar. When we compared the long protocol with PPS, lower gonadotropin consumption was made in the PPS protocol, and the number of oocyte retrieval was similar. Interestingly, the PPS protocol might be flexible, like GnRH antagonist flexible protocol. Rather than starting progesterone on the first day of stimulation, we may start the progestin at the 6th to 7th day of stimulation when the follicle reach around 12 to 14 millimeter in diameter. This is very likely to a flexible GnRH antagonist protocol. All the studies comparing this protocol, efficacy of this protocol coming from Turkey. The first study was made in normal ovarian reserve patients in donation cycles. Flexible protocols are comparable with GnRH antagonist protocol. We know for premature LH surge, diminished ovarian reserve patients are much more vulnerable. When made a comparison for flexible PPS and antagonists in the diminished ovarian reserve patients, the results again were similar. Also, PPS were compared with flexible PPS with the standard PPS, fixed PPS. Again, the results were comparable, but all the studies are retrospective design, and also the sample size is low. Why the flexible PPS is important? Because as a clinician, we don't have to make a freeze-all decision on the beginning of the cycle. We may make our decision based on the patient response on the mid-cycle, because some patients unexpectedly will respond higher to ovarian stimulation, and we may change our mind from fresh transfer to freeze-all cycle, and we can reduce the cost by using flexible PPS protocol. Another protocol is random start PPS protocol. This is tested only in this study. We need further studies, of course. This is the fertility preservation setting, included patients with breast cancer and hematological cancers. Of the included, 86% were compared in terms of protocol used in the random start PPS protocol. Regardless of the day of cycle, progesterone and gonadotropin started simultaneously the same day. And when we compared the results, the HMG dose used were similar, maturation rate were similar, and also fertilization rate were similar, rates were similar, good blastocyst rate were similar. But of course, we need to replicate the result by the other groups and with the larger sample size. The question is whether PPS has any detrimental effect on oocyte competence. Actually, based on the available data, only one is RCT. Most of the studies are retrospective trials, but PPS likely does not have and compromised oocyte competence when compared with GnRH antagonist. Vast majority of the studies reported similar fertilization rate, similar blastulation rate. Only one study reported lower blastulation rate, but with the high risk of type 1 error, and one study reported lower good quality blastocyst. Two studies reported, but actually the same data reported lower good quality blastocyst rate with use of PPS. Any effect of PPS on euploidy rate in different 4 studies. These were tested in Italy, age-matched control group in PGTA setting. When compared the results, similar euploidy rate in China 2 study, particularly the study by Yang et al. Compared the euploidy rate and stratifying by age and reported similar euploidy rate. The recent one included only patients with advanced maternal age undergoing PGTA, and similar euploidy rate were reported. But conflicting data exists. However, this data has major limitation because of the conflicting data published in 4 studies. Of those 4 studies, 1 reported lower euploidy rate, and 3 studies reported lower cumulative live birth rate with the use of PPS. But as I said, these studies are non-randomized, mostly case-controlled studies. Only 1 propensity match control studies, and suspiciable high risk of selection bias. The first one, which is the propensity match control study, trying to report cumulative live birth rate, actually did not use the standard definition of IGMART glossary for the cumulative live birth rate, and use the time frame to define the cumulative live birth rate. And when we look at in detail, a higher number of embryos awaiting for the transfer in the PPS arm, which makes, the comparison for the cumulative live birth is invalid. Only one study reported higher aneuploidy rate in the PPS treated group actually, but the sample size is very low, 34 patients, only PPS arm. And I should stress that aneuploidy rate reported in the study was significantly lower, actually not when compared with the standard literature, questioning the validity of the genetic platform and PGTA lab. The other two studies are published by the same authors and by the same groups. Actually, they used almost the same data by adding the other groups in two different journals. The problem with the studies, they include the PGTA-M and PGTA-SR studies. Although the mean age were comparable, age-stratified comparison were not available in the study as in the result session. So these are again the case control study which make a high risk of selection bias. Considering the limitation of the few conflicting studies, it seems that highly likely that PCS does not have any detrimental impact on oocyte competence or euploidy rates. When we look at the perinatal and neonatal outcome, few studies are available. This is the larger sample size one, reported similar perinatal and neonatal outcome. Regarding congenital malformation, a recent systematic review meta-analysis including more than 10,000 live births treated with progesterone ovarian stimulation did not find any association between the PPS and congenital malformation. Progesterone ovarian stimulation is cost-effective in freeze-all cycles because you don't, if you already decide to freeze all, it's cheaper than the other pituitary suppressors, and also you need fever monitorization during the ovarian stimulation follow-up, and which means indirectly reduction of the cost for center and for the patients. Recent publication compared in a fertility preservation setting the cost effectiveness of GnRH antagonist and PPS. As you can see, PPS is cost effective. Freeze-all approach gaining popularity over the last decade. The main contributor for the increase in freeze-all approach is the increasing number of PGTA cycles all around the world. Actually, the freeze-all approach can be divided to two groups, the elective freeze-all or non-elective freeze-all. Elective group include PGTA, dual stimulation, the patients with endometriosis and adenomyosis, patients and doctor's perspective. Non-elective group, high risk of OHHS, late follicular phase progesterone elevation, which is associated with detrimental reproductive outcome, and embryological or uterine or tubal reason, which did not allow clinician to make fresh embryo transfer. Is freeze-all for all actually several randomized trials in different patient population has been published over the last decade, but based on this randomized trial, recent cohort meta-analysis clearly showed that dividing the studies according to day of embryo transfer, cleavage stage, or blastocyst stage transfer, overall no difference in cumulative live birth rate in freeze-all or conventional IVF cycle. Obviously, freeze-all is not for all, but there is a heterogeneity between the studies associated with the included study population. We acknowledge this, and since this heterogeneity exists between randomized trials, efforts to identify individuals who would benefit most from the freeze-all approach is ongoing. This is the individual patient data meta-analysis protocol published in BMG Open last year. We are awaiting for the results of this meta-analysis to identify the patients who would get most benefit from the freeze-all approach. Based on the available data, to whom we should consider PPS, actually all patients who is the candidate for freeze-all approach can be, for PPS might be the first choice of protocol. These are the donor stimulation patients, fertility preservation patients, and PGTM and A cycles, also dose stimulations, and the patients who are under the risk of high OHHS risk should be the candidate for PPS protocol. To conclude, for such a wide topic, routine use of progesterone for follicle synchronization is not recommended according to low quality data. Progesterone may help us as a clinician for scheduling the ovarian stimulation cycle and avoid from the holidays and the weekend egg retrieval and adjust the workload on the laboratory part. Progesterone might be the first option for inducing withdrawal bleeding. Only secondary analysis of the one study, it's associated with higher liberator rate when compared with the OCP. Levonorgestrel IUD should be the first choice for treating endometrial hyperplasia and early stage cancer prior to IVF. And also hysteroscopic examination during follow-up should be the recommended one when compared with the dilatation and curettage, because dilatation is curettage associated with compromised implantation rates. Low quality data suggests treatment of endometriosis with progestin 2 to 3 months may improve the liberator rate when compared with no treatment, but obviously we need further studies, well-designed further studies. Regarding the PPS protocol, it effectively prevents premature LH surge and also yields similar number of oocyte and M2 oocyte. The flexible PPS and the random start PPS are new protocols and appear to be feasible. However, we need further studies to validate their effectiveness. Based on the local data, PPS does not compromise oocyte competence. However, the data is coming from the retrospective studies. Still, randomized are needed in this context of PGT. Similar perinatal and neonatal outcomes were reported when compared with antagonist protocol. PPS is a cost-effective suppression protocol in freeze-all cycle compared to generic antagonist. I would like to thank you all for your attention. I would be happy to answer if you have a question.
Thank you very much, Sezcan, for this complete, thorough presentation. I'm sure there are questions from the audience. If there are, I didn't receive any written questions. While we are waiting for the question from the audience, and please let me know one way or the other that you want to make a question. Maybe here we have one. Thank you for the wonderful presentation. It's not a question. And so in the meantime, I may start with a consideration and a question. So you explained very well that we shouldn't consider neither progesterone nor other pre-treatment to ameliorate the follicular response to synchronize follicular growth, but certainly I'm pretty sure that we all agree that in everyday practice we need scheduling, and we will always need scheduling, especially in big centers, very busy. It's impossible to do without it. So I have a question and a consideration. I wonder why, if now it's so clear that estroprogestin, so the pill, reduce the results, the scheduling with pill reduce the results, I do not understand why another kind of pre-treatment with another steroid, with progesterone, couldn't do the same. Do you have an idea to explain
Actually,
this?
the recent cohort included 6 randomized trials. Of those included trials, the progesterone part was desogestrel and levonorgestrel. It might be related with the progesterone itself or the combination itself. We all actually know that OCP strongly reduce the LH secretion from the pituitary. So based on the study published in 2007 by Sezcan clearly showed that the washout period of 5 days would be enough to recover the LH level in the blood circulation. So the data is coming from the heterogeneous group of studies and in the cohort, and Esche used the data coming from the cohort. Actually, I should acknowledge the included studies are not similar in terms of washout period. Some of them have short time and did not consider the washout period enough. So personally, I believe that OCP pretreatment would not be detrimental if you put enough time for pituitary to recover. So,
which is 5
so the data is low quality, but the washout issue is not resolved yet. But for the scheduling, it seems that based on the available data, progesterone pretreatment might be a better option than the OCP.
Okay, we have a question. Thank you for. On which day there is a question from Prasad. If you write also where you come from, it could be even more interesting. So we know we are talking to whom we are talking. So this question says, on which day you start the progesterone in ovulatory cycle? Is it 14th day or 21st day?
I start around to 20 days, 20 to 21st days. I mean, the answer is not the 14 days.
So the 20th day of the cycle
previous
before.
cycle before ovarian stimulation.
And we have another question from Chen. And comparison between progestin and estradiol priming, both ineffective or estradiol priming is effective?
Yeah, actually, good question. I cover only the progesterone part during my presentation because pretreatment is another, topic that we can make a presentation for 30 minutes. I did not include the estrogen priming, but according to recent cohort and low quality data, 2 studies showed that estrogen pre-timing associated with significantly higher oocyte retrieval rate, but there is no difference in the live birth rate or clinical pregnancy rate. So the answer is not the same, but since the data is very low quality, that's why the Esche ovarian stimulation guideline do not routinely use of both estrogen and progesterone. But personally, I believe that, and the data is suggesting estrogen priming might be much more beneficial in terms of the number of oocyte retrieved. Recent RCTs published after the cohort review in human reproduction 2 years ago. Internally in our clinic, we discussed the result with my colleagues, and that RCT was showing no benefit of using estrogen pretreatment in terms of ovarian stimulation outcome and reproductive outcome. But in the subgroup analysis, for those patients with poor ovarian reserve and diminished ovarian reserve, the benefit of estrogen pretreatment might be much more, because we all know that those patients has short cycles. Short cycles is associated with early recruitment of the follicles and early selection of the dominant follicles, which might be associated with the asynchrony in the ovarian stimulation cycle. Shortly, I believe, based on the data again, estrogen pretreatment might be much more beneficial than progesterone pretreatment in terms of number of oocyte retrieval.
Okay, thank you. And Prasad said that he was from India, and thanks for the answer. But when you're talking of estradiol priming, this is my question. Do you refer to the use of estradiol in the previous cycles or in the same cycle? Because
Yeah,
there is a
actually, yeah,
very recent work in
actually, the
Genmore.
data from India published 2022 in Fertility Sterility Report, they are showing that you can use estradiol timing even in the stimulation cycle, in donation groups. I mean, so for scheduling, estradiol is working well, but it's out of the, I mean, topic for this discussion. So that's why I
Yes,
didn't mention about
yes,
it, because we are
yes.
talking progesterone.
Okay, let me see if there are other question for you from the audience. Yes. With the use of PPOS, do you see longer use of FSH and HMG, days of injections, ATA from Malaysia?
No, actually,
So if
data
you,
is convincingly showed that when compared with GnRH antagonist protocol, the duration of stimulation is almost similar. But if you compare it with agonist, few data show that PPS end up with shorter duration of stimulation.
Okay, so if there aren't other questions at the moment, I had another question for you. According to the last ASHRAE guidelines on ovarian stimulation that are dated 2019, so is 4 years have passed. The PPOS protocols are regarded as not suggested, not
Yeah.
suggested, and especially the use of progesterone for LH peak suppression is probably not recommended, it says. If applied, can only be used, of course, in non-transfer cycle. Now, my question for us is, after 4 years and all the evidence that you presented in this, in your presentation, do you think that it's time to consider these protocols, this progesterone priming in cycles, in the freeze-all cycle?
Actually, I personally
Standard.
use it every day in freeze-all cycle. I
You
personally use it every day in freeze-all
every day.
cycles. Yeah, so I do
So,
believe that
which progestin do you use?
I am using dydrogesterone twice daily, 20 milligram per day. Dydrogesterone.
Twice daily.
Yes. No, yes, twice daily.
Twice daily. So,
I mean,
so we can.
accumulating data is convincing enough me that it do not have any effect on oocyte competence, and also it efficiently suppresses the LH search and yields comparable oocytes number. So why? I mean, it's also the cost is very low when compared with other pituitary suppressor. So since it is cost effective in the freeze-all manner, I am using in the patients in which I have already decided to do freeze-all, as I mentioned in my presentation. For those patients with PGTA cycles, patients with dual stimulation, patients with high risk of OHHS are the most, I mean, candidate who would benefit from the price benefit of the PPS protocol.
Since I would use it especially in fertility preservation cycle, I still have a doubt, and I think you don't have an answer about this. About the use of additional progesterone administration in hormonal sensitive breast cancer. What do you think?
Yeah,
And
I
your
mean,
comment.
I actually discussed one study. They usually use progestin along with the letrozole for those cases. You might be right. if you are using it fertility preservation manner, using progestin for the patient with breast cancer with positive progesterone receptors in their, cancer tissue, might be one point that we should consider for those cases. But in terms of the estrogen, they all, combined with the letrozole during the stimulation.
Yes, the estrogen, yes, but the letrozoles have no action on the
Yes,
progesterone.
sure. You're right.
Are there any other question from the audience? Otherwise, I go on making question myself. So so for scheduling, we have talked about scheduling that we can do without it. And so you would suggest to use progesterone as for scheduling. And can you, in that case, which progesterone do you use?
Based on the Fisher protocol, because this is, validated data, I prefer to use norethisterone acetate.
Yes, and so can you motivate why you choose norethisterone to schedule and dihydrogesterone to prime?
Actually,
Is there a rationale?
no data available comparing the different progesterone in terms of dose and the type, because available randomized trial only included the micronized progesterone, dihydrogesterone, and medroxyprogesterone acetate. So I don't know, since I don't know, I don't have the comparison with the already established progesterone for the norethisterone. That's why I'm not choosing that one.
During the cycle.
Yes, for the PPS.
Otherwise, you would prefer it because it's stronger.
Yeah, might be, but need further studies.
Okay, we have another question. With the dihydrogesterone suppression, can you transfer blast in fresh cycle?
No, absolutely. Because you are not prepared your endometrium timely. If you are asking the question in the point that dihydrogesterone can be used for the luteal phase support, but if you do not make the timing and the progesterone use and scheduling are actually overcoming the problem with the duration, it's not possible to use dihydrogesterone, because if you use it for 20 days, how would you open the window of implantation? Because window of implantation is, opened based on the progesterone, and maybe the long use of progesterone should affect detrimental effect on endometrium in terms of implantation.
So, and I have a question about endometriosis. Do you use well, do you, in your protocols in your clinic, do you do the 3 months pre-treatment with progesterone? No.
I don't
Neither
do.
in adenomyosis.
No, actually, I do
endometriosis.
long GnRH agonist pretreatment for a long time, long suppression, and I prefer
long
to
how many months? So not just a long
at least 2 to 3 months. It's first I do egg retrieval and freeze-all cycles. As I mentioned, this is an elective decision for freeze-all. After the suppression for 2 to 3 months, I transfer the embryo in a frozen embryo transfer cycle.
But for fresh, for ovarian stimulation, before ovarian
limited
stimulation.
data show that rather than doing, I'm talking about the first endometriosis and second for the adenomyosis. For the endometriosis, I'm suppressing this patients for 2 to 3 months before the embryo transfer. Actually, it's not validated. Recent cohorts show that long suppression is not beneficial for endometriosis cases, but previous one showing that it might be beneficial for some cases. The answer is not given yet for the endometriosis cases, but accumulating data for adenomyosis patients, doing embryo transfer after the at least 2 to 3 months separation might be beneficial for the patients. So the quality of the data is limited.
And why do you prefer the long GnRH protocol instead of progestin? Have you a reason
I mean, only one study. I showed that only one study comparing the long agonist suppression with diagonist treatment, and long agonist suppression is better than diagonist. Diagonist.
And well, I wait for other question from the audience. Do you have any other question on the progesterone protocols for hyperplasia? What about adding metformin for hyperplasia? And
actually, 2 studies, as I showed in the table, added metformin along with the medroxyprogesterone acetate and megestrol acetate, and yielding good result. But there is no data comparing directly adding metformin or not. So I mean, personally, I don't think that adding metformin would make that much sense. So my first choice nowadays is levonorgestrel IED for the treatment of hyperplasia and early stage endometrial cancer. If I could not get enough response following 6-month treatment, I may add an additional oral progesterone to intrauterine progesterone.
you prolong the treatment. After 6 months, you prolong the treatment.
Yes, actually.
How long do you prolong
depends,
the treatment?
I mean, it depends on the country variable, and as a clinician, your preferences. European guidelines recommend to check the response at the 6 months of the treatment, but the US guideline recommend to check treatment on the 9th or 12th month after the starting the treatment. So personally, I check first sampling and the 6th month. If I did not get enough response, to levonorgestrel IUD, I add additional oral progesterone to get the response. Actually, a response rate in the first 6 months is around 65% to 70%, and prolonging the treatment and adding the treatment, the response rate will be increased up to 90%. Refractory cases always is available, but I mean, these are only around 10% of the cases.
Do you have to remove the IUD when you do the hysteroscopy to check the...
No, you don't need to do this. You don't need to do this.
You leave it there, and then if
Another question. I mean, in the literature, whether using hysteroscopy would increase the risk of recurrence of the disease and the spread of the disease to the abdominal cavity through the fallopian tubes. Actually, this is questioned for over the last decade, and several publications showed that yes, you are spreading the malignant cell from uterine cavity to the abdominal cavity, but it is not associated with the progression of the disease. And also remission is higher when you use hysteroscopy when compared with the dilatation and curettage. So hysteroscopy is safe for those cases, because if you use dilatation and curettage for several times, you may, cause an irreversible damage to your endometrium and the basal layer, which end up with Asherman, like compromised implantation during IVF. And the mortality rate for the fertility preservation for the early stage cancer is less than 1%. So it's looked like, treating the early stage endometrial cancer and considering the fertility preservation looks like safe, for those cases.
And do you have a large experience of treating hyperplasia and early?
Yes, we have. Actually, we are, tertiary center. All the patients are referred to our center for those problems. We made 3 publications for those cases, and the first one was the first baby in Turkey from the fertility preservation manner for early stage endometrial cancer. So we have a lot of experience for those cases. So hysteroscopy is
Because,
important.
I mean, having a large casuistic, since endometrial cancer, unfortunately, is not the most frequent cancer in reproductive age people.
Yeah. Since we are
is-
discussing the pre-IVF use of progesterone, this is the one aspect that we should discuss. You are right. I mean,
Yes.
we are not
Because
encountering every day such kind of patients.
because I deal with fertility preservation in cancer, but in my in my history I just saw 2 endometrial early endometrial cancer because of just the frequency, no, of the disease. So interesting. Are there any other questions? We don't need to stay here until 5 o'clock for me, and whatever hours is for you. If there are no other questions, I think if Seth can agree that we can also finish before.
Yes, sure. If the listeners are okay, if they don't have any other question, and if they are, I mean, well with the presentation, we can finish the webinar.
Okay, I don't see any other question at the moment. Can we get the tape? This is a question. I think yes. I don't know. You, I think you can get the tape. Yes. So it has been a pleasure for me to meet you, and I've learned a lot of things about progesterone protocol pre-IVF, which is a funny title. In fact, I wasn't sure what you were going to talk about.
First, when I first heard the title, I was shocked. What should I talk about that? But I think I handled. I mean, I
Yes,
summarized all the data.
you definitely handled very well. Thank you very much.
It's my pleasure.
And
Also, thank you for your very nice, I mean, chairperson position. Thank you for your kind questions, and thank you very much. It's my pleasure to meet with you.
okay, so where are all the interpreter? I think we can close the session, and I hope it has been useful for everybody. Liam, do you agree that we can we close it earlier?
Yep, absolutely. If you guys are all set.
Okay. Thank you then. Thank you to everybody.
Thank you
Thank you
all.
all as well. Have a great rest of your day wherever you happen to be.
Thank you.
Okay,
Bye-bye.
Meet
bye-bye.
you again in any part of the world.
Bye-bye.
Bye.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye.